Health is an important part of everyone's life, and good health determines how productive a person can be and how much they can participate in daily activities. However, getting access to quality healthcare is a major factor to staying healthy. In Nigeria, some of the challenges affecting healthcare delivery are poor and inadequate infrastructure, obsolete and dilapidating medical equipment, poor and inadequate distribution of health workers, poor quality of healthcare services, lack of essential drug supply, amongst others. The collapse of primary healthcare centers nationwide has also contributed to the worsening situation of healthcare delivery in the country. Well, joining us via Zoom to discuss more on this is Chairman, Save a Life Group, owners of Save a Life Mission Hospitals, Save a Life Tech Hub Limited, and Save a Life Communications Limited, Dr. Richard Okoye. Good morning. Thank you for joining us.
Thank you, and my pleasure, and thank you for having me.
You're welcome. Now, there are those who say that if you do not know where you're going, you should know where you're coming from at least. And so let's begin with the matter of how we got to this point, where reports are saying it is only about 25% or even less of the primary health care across the country that is functional.
Yeah, basically, the situation in healthcare sector in Nigeria right now is quite, it's kind of being in a deplorable state. But fundamentally, for addressing such issue, you have to first of all understand what has actually brought us to this particular point. We must understand, as you people have actually emphasized so much on that, on the issue of Japa syndrome. Of course, fortunate to mention that in most of the communities in Nigeria today, you will hardly see any doctor. So the fate of those ones actually hanging on a balance. In the same accord also, we have this very misconception as it were, when we are talking about healthcare, we are looking at infrastructure. So most times you see government, you see agencies build a structure and say we've just built a hospital. Hospital is much more than infrastructure. It's much more than equipping. Otherwise, the best hospital ever built has to do with the issue of a born specialist hospital built by the current Senate President, Senator Fabio. But very unfortunate that if we get through most of our teaching hospital, we see a lot of latest equipment that can testify to that. But majority of them have been abandoned. Simply because most of the times when we want to do a hospital building and equipment, we put it from the contractual kind of engagement in terms of acquisition, whereby you give a contract to somebody, import equipment, not considering the person who's going to use this very equipment. A doctor that may even have trained on the use of, maybe look at the Cadillac, for instance, for this heart. He may have trained with a Philip equipment wherever. And the government will give a contract without minding or taking the opinion, those that will handle this equipment, what are they used to? So most time we find that we bring those equipment, commission, the first person that will touch the instrument will get it damaged and repair become and also service thereafter. But the worst that is actually happening right now, we admit that the primary healthcare has totally collapsed. But the one that is more destructive, as it were, is allowing healthcare to go under Band A implementation. I can talk to you today, many hospitals have shut down on the basis of that. Some are thinking of alternative power supply, which obviously will make most of those hospitals not being able to sterilize the equipment nicely. And of course, if you leave a particular place with a particular temperature, more organisms will grow. And so we have now, as another challenge coming up, nosocomial infections. Infection coming in from issue that has to do with hospital acquired. Because if you allow those organisms, over time they undergo mutation, become resistant to the existing antibiotics, and it's going to be a disaster. In my hospital, a couple of weeks ago, or 2 weeks ago, I was given a bill of 43.9 million in the name of Band A. And while we even paid 8.5 million naira and pleaded, we said, so look at the end of the month, let us pay salary for the people that will even generate this money. That landed on a deaf ear, and they came and cut off the light from the hospital. We bought diesel, that unfortunately it was a bad one also, that shut down the generator. It was a commotion that we have to discharge our preterm babies. Those that just did kidney transplant, we are in a terrible state. So that's why when you look at quality, I think it is something we may reserve for now, but to be able to address these fundamentals. There are 3 tiers of healthcare. You have the primary, you have the secondary, and you have the tertiary. Collapse of primary and secondary healthcare now in the country has put pressure on tertiary institutions, which otherwise should be dealing with multi-specialty discipline. But today, you get to teaching hospitals that are treating on cough and catarrh, they are treating diarrhea. These are not what is actually designed to be. So it is a very unfortunate situation we have been able to come to. And as a matter of as quick as possible, if something technology will aid, we have to take action before it becomes too late.
Absolutely. You've actually, listed a whole lot of issues that Nigeria primary healthcare system sector is actually facing. But come to think of it, we have healthcare facilities that are dilapidated. Some are being, they're not even having access to quality, service and all of that. But if you look at what the WHO says, that Nigeria has only one physician for every 5,000 people, which is far below the ratio. So how do you think we can bridge this gap? Somebody like you who had practiced, for several years outside of the country, thinking of coming back to Nigeria to invest and, give back to the society. So how do you think we can help Nigeria, bridge this gap in order to implement this, to improve rather the physician distribution?
Basically, we must have to admit, as earlier said, that healthcare is beyond the infrastructure. Regrettably, we are dealing with a mobile intellect trade. What I mean that mobile in the sense that a doctor is moving, a nurse is moving, pharmacist is moving. So you are dealing with mobile trade. And internet has made the situation worse right now, where a doctor that is in a local community knows what a doctor in New York is earning. So, and our economic situation right now is also not helping matters. In other words, it gives us no chance to be able to say, how do we be in position to keep all of them here? Now, good news is that technology has been able to help, because it has been a burden to me. How do we reach out to those ones in rural communities? And we started a particular EMR, which we are targeting to be able to at least download the brain of a doctor, of a nurse, a pharmacist, that could be available for those in rural communities. And we have been able to develop that in such a manner that a person or someone in rural community can answer those questions that Dr. call, clerking, in their own language. Some will also make it to be in the native language of the people. That's the capacity we've been able to do that. When they answer those things in the villages, it can get to the city. The doctor in the city can look at it, can also be in position to communicate to them. But we have a major limitation which we've been able to solve in that area. How do we, by reason of internet and by reason of this? So we initially wanted to use what is called radio frequency, synchronizing 2 radio frequencies. But looking at the topography of our nation, hills and all that, it means that we are going to mount a lot of mass all over the whole place. So we got the idea to say, okay, let's be able to, on the wings of the existing telecommunication companies, which have been able to reach out to most of those communities. So we now build different gadgets that uses SIM-card. Like if you check out, this is one of our products. This very product, apart from the issue that it has a battery here, all right, it also has the MTN SIM card right in there, all right? So with that, if they take their BP in the villages, they take their vitals, we can also see. In one occasion, we went for a particular community in Port Harcourt, pregnant women all over the place, but there's no single doctor. So on the thought of what is the fate of these ones, and you know, when you look at the issue of life expectancy, it's majorly based on mother and children. So how do we help them? So we created an app that has the capacity that while those pregnant women are there, we produce this very urine test that can show the sugar and also the protein. Because if such a woman has something like preeclampsia, she's dead. Nobody to help. So we created this that while someone can be there for them, open up this and just use one strip, put it in their urine for 1 minute, they can use their phone to match the color. So we did it and it's been found very fantastic. So when they match this very color here and click on it, we can see. So that's how we've been able to pick up those women that are having protein in the urine or glucose in the urine. And of course, you know, their condition require multi-specialty management. So we can be in position to pick them through our foundation, Dr. Save a Life Foundation. And that's why we are optimistic that despite the fact that the doctors are not there, nurses are not there, there is hope that those ones in the rural community will be able to access. And we developed a computer. It's the first computer currently that uses SIM card. That because being able to keep that in the village, they can use it to clock themselves. Doctor will see and can do a telemedicine based on the fact that it's no longer asking a lot of questions. We already see what the patient has communicated. So these and many more we have been able to put in place. I'm very, very optimistic. It's not going to be this very bad, you know. But I want to appreciate the federal government for the effort of, you know, pharmaceutical products, you know, having been given a waiver in that regard. But Nigeria, we know, and in other countries, when such a waiver is given, there is also what is called regulation. Because if we put it the way we put our naira into the market forces, if the person clears it cheap, he will come and play the game across the market forces. But if we're able to do what other countries do, which is called MRP, that's a marked retail price, we will be able to make these very drugs reach out to all those local communities in a manner they could be able to afford it. Yes, it could look as if it's a challenge considering some people may clear in Lagos how to travel down. So that's why we can disseminate or decentralize the policy or the regulatory body in such a way, even if you are in Port Harcourt, this is what you can say this product. In Lagos, this is what, even if we don't do, you know, all of the medical, in all the drugs, we can look at the vital ones that could be able to at least save the life of a person that is right there in the community. So that's one of the things we're quite optimistic that by the grace of God, you know, it's not going to be this very bad because we've created an EMR that answers the question a doctor should expect you to answer, and also being able to ensure that issue of what they call iatrogenic death. You know, most times what causes death in our society, maybe there's an error. The system prevents the doctor from doing an error or prevent the nurse from giving whatever. So it guides the doctor, guides the nurse, both in the issue of diagnosis, in the issue of investigation to run, in the issue of also the drug to be given. If there is something like what they call drug interaction, once you give one drug, the other one disappears from the system. If a patient is allergic to a particular drug, once that diagnosis is tagged to that person, you can't see that particular thing that will trigger as allergy or whatever in that very person. So we are looking forward to something really big and something that will be quite helpful. And finally, when you look at the issue of government effort, actually, you know, when we build a hospital, before building, we should consider who are those that will even man this hospital? Who are those that will even man this equipment? Who are those that will be able to? They are more important than the building we are talking about. That's why we have a lot of abandoned infrastructures, it's not that they're not there, but abandoned, ranging from primary now even to the tertiary institutions. So I think it is something that optimistically I will still maintain that something can still be done here.
Absolutely. And I'm glad you talked about how you are looking at spreading across the country, because that was one of the questions I was going to ask with regards to the innovations you have put in place, how we are going to ensure that it gets across the 774 local governments of the country and not just one location, so that people, especially mothers and their children, everyone can benefit from all of these products that you have shown us this morning. But let's quickly go to this other issue, talking about the year 2030, where universal health coverage will be a reality. Are we prepared to meet up with this target, considering the condition of the current condition of our healthcare system? You have said you are optimistic, but we have 2030 that is just about 6 years away.
Yeah, I strongly agree with you that looking at the current situation, of course, we are not near. And it looks unrealistic. But that can only be done, as earlier said, with the aid of technology. We are dealing with mobile internet. That is one of the key things in the business of medicine we must have to admit. If a doctor is doing well here, people will be coming for the sake of that doctor. If he leaves that system is collapsed. So it becomes imperative for all to be able to understand these are the people that attention should be given. They should be given the attention. We should not just allow doctors to be going on strike and all that. The more they go, the more people that don't even intend, maybe those that may have been given, like even if as a calling, to be in those communities, we begin to think whether it's a missed call they got or something in that very nature. So the universal health coverage now, we can achieve it with what I have projected to us. One is that our system, the computer we developed, which we are not limiting it to Port Harcourt, no, even to other hospitals, we're also looking forward to spread this very technology to them. This technology can be in position in a community. We could be in position to train someone there to be able to just ask simple questions. Mama, you say your baby has fever, yes? It's 2, 3 times, it's true, how many times is true, this other one, all those clacking questions. But now, most importantly, in the language of the people, you know, our medical terminology actually brought the confusion that is in healthcare. If a doctor wants to tell you have malaria, I tell you have plasmodiasis. The longest word in dictionary is a disease, a 45-letter word, pneumono ultramicroscopic pneumoconiosis. So you look at those grammars, it tends to confuse people. So we broke it down in a manner that those ones in the village can answer those questions. It gets to the doctor, even those in the United States, in Europe, we can connect them to be doing a social support to their own community, which they will be willing to do. So once they answer those questions, it gets to any of the doctors in the city or wherever that may have a volunteer, and we call back and ask him, madam, you say your baby has this, yes, he has this, yes. Okay, your baby has malaria, okay, I'm sending you a drug. Now, he send a drug to that particular, what we call community chemist. In that community chemist, they will pick the drug. As a matter of fact, what we have been able to build so far is that even while taking their drug, we know they are taking it. And they will be able to review so that the drugs that are not doing well or people are not responding well to or causing one particular kind of allergy, we will pick it up on time and can reach out to the manufacturer and say, look, people have been having this kind of scenario. It's not when it has already become an epidemic before we realize to do something ad hoc, you know. So, and those drugs that they have in that community, as it's disappearing from the, as they are buying it,
all right,
from the city, we could be able to find out what is really happening.
I just want to quickly ask if this innovation you have come up with is just for pregnant women and children. There are those who ask, what about the men? What have you put together for the men and other categories of persons in the society to address the health issues they are also facing?
Absolutely. We have been able to address the issue of this sudden deaths, all right? This particular product is actually designed to take out what is called a paramonitor. We compress that paramonitor in a manner that you can check your BP, you could be able to check your pulse, you can check also what they call oxygen saturation, you can read your ECG. But we use the same technology that while somebody may have a chest pain, breathlessness, or sudden form of collapse, instantly, this very fellow could just plug in what we want to show us here. All right? Let me plug in what we want to show you here. Plug in what I want to show you that fantastic. Once you plug it, you can read the reading of that very heart, a doctor elsewhere. And we want to put in something in the pack where you can have emergency drugs. Please pick up from this bag and chew it. You can save a lot of people in heart attack. All right? And the same thing also for stroke. There's what is called arterial blood pressure. If it reaches 130, that fellow will have stroke. So we now designing so that while you are checking your BP, you can see the danger sign clearly. And as you take that to your BP, if the BP can be connected to your doctor, can be connected to your hospital, can be connected also to your phone. So we currently have about 106 servers in the United States. So obviously we are developing a capacity that should be able just to help out in terms of danger, and a number of other stuff actually coming on board. So optimistically, as I earlier said, it's a bad situation in the country, but we are not completely losing up the hope, having understood the etiology, the actual cause of these very deficiencies we have in the healthcare system.
Absolutely. Quite, an expose you have actually given out there. I'm someone who doesn't miss your programs on Sunday on our channel because you say a lot, you make things very easy for people to understand. But then you've actually addressed the literacy gap, or let's say the knowledge gap, getting to the rural areas, trying to expand your initiative. But how do you take advantage of this, or how do you think government can take advantage of some of the innovations that you bring into medicine, the simplicity, in terms of public-private partnerships, which you think the government can leverage to revamp our primary healthcare sector, or generally the healthcare system, the healthcare delivery system, which, if you look at the initiative of the Nigerian Private Sector Health Alliance, they said it was successful. So how do you think government can actually key into this to make healthcare delivery easy or accessible for Nigerians?
Absolutely. Just like I said, it's something born out of passion. And it's not also something that should be exclusively for Save a Life Mission Hospital. No. It's something that we are looking forward to be used beyond even, the problem of Nigeria is also the problem of other African countries. All right? So in that very case, it's something that is open for everyone to use. But we have been able to be patiently, because it's a technology that is 10 years old right now. We have been on it, trying to ensure, let it not be like an African thing. So that's why if you look at some of these our products here, we call it like, let's be in position to trust Africa for once. So if he has a problem, we can say, return this and we give you another one. It's the kind of ruggedity we are building into it. So that's why if you look at the demo of this right now, you can see this to be able to show someone the BP, the pulse, the respiratory rate, and also the oxygen saturation. Now, very handy, you can see, and mobile, and also you can see the ECG. This is like 4 machines contracted into one, being mobile, that when people have those cases that otherwise would have been a story to tell, they could be in position to use it. And together, and it's going to be something open for all, open for government partnership, organizations, for communities. It's something we have to do together, because we are many. It's not a one-man, it's not going to be a one-man show, but it's something that everybody's going to get involved. and together we can build a very, very healthy society. Optimistically, we are there.
So what more innovation should we be looking forward to from the Save a Life Foundation?
It is something that is actually continuous. Healthcare, like what we did is that we're able to use FDA-approved drugs. So, and FDA used to update their records every Tuesday, all right? So we have been able to synchronize our system alongside with the FDA routine evaluation. So apparently, what is obtainable here in Nigeria, you can see the updates, and what is obtainable in India, in United States, in UAE, all those places has actually been tied up in that particular aspect. And we are looking forward that a number of things, as events unfold, when AI will also be in position to take more predominant, and when 5G will also be able to do a lot, a number of remote things can be done. So if we pick up people that are having issue at that primary level, and we create a central place at the local government aspect, that local government, we could be able to say, okay, a woman has a 2P pregnancy, move her to that very central location in the local government. A doctor from the city can come and operate the person and still go back, while the monitoring is also done remotely, since we don't have enough of these other doctors, So, and if a person that is having something that may require admission, so you find out that a movement cannot be made from primary to secondary to tertiary as applicable. And not everybody moving to the tertiary institution for cough and catarrh. For things otherwise, even like what we do for most of those women, traditional birth attendants have been the hope of those women in different communities. So instead of talking against them and saying that no, they're not good and all that, we try to teach them. If a scenario like this comes, please call a doctor. If this kind of a scenario, the issue of preeclampsia or somebody that is having a cephalopelvic disproportion, if a woman in labor gets to this and you see this sign, please call in. So we have been able to bring them on board, training them on some of they should be able to see.
And that's a good one, having to bring on board traditional birth attendants to train them. We must thank you, Chairman, Save a Life Group, owners of Save a Life Mission Hospitals, Save a Life Tech Hub Limited, and Save a Life Communications Limited, Dr. Richard Okoye. Thank you once again.
Yeah, great pleasure. Thank you for having me.
All right, and still to come on the program, Nigerians can now heave a sigh of relief as federal government suspends import duties on some essential food items. Join us after the break for this conversation.